بسم الله الرحمن الرحيم. أبنائي طلبة وطالبات المستوى الخامس، اليوم هنتكلم في الجزء الأخير من المحاضرات تبع الكلينيكال يورولوجي، وهنتكلم فيه على كلينيكال سيناريوز لمرضى اليورولوجي من مختلف الديزيزز. هو very interesting الحقيقة. احنا اتكلمنا في المحاضرة الأولى عن clinical presentations of the patients اللي هو symptomatology and how to examine each organ من urinary system. وفي المحاضرة الثانية كنا اتكلمنا على different investigative maneuvers and modalities اللي مطلوبة للمرضى نعملها، واليوم هنطبق الكلام هذا على clinical scenarios بطريقة بسيطة وسهلة. الحالة الأولى اللي هنتكلم عليها هي حالة مريضة عمرها 32 سنة. She is pregnant, present to the emergency room with right-sided flank pain. Renal ultrasound did show right hydronephrosis. يبقى هذه مريضة عمرها 32 سنة وبريجننت، اجت على الطوارئ برايت hydronephrosis. معناته اجت على الطوارئ معناه there is some sort of severe pain in this patient. What is the differential diagnosis? Let us think before just shifting to the other slide. يعني hydronephrosis in pregnant ladies could be physiological, could be pathological. Well, pathological, like any other patient having some right loin pain or right flank pain. Let us see how to discuss this thing. It's a very important patient. She is pregnant and having a baby. Let us take care of her. Let us see how things will go. Although the same differential for hydronephrosis, flank pain for the pregnant and non-pregnant is the same more or less. But physiological hydronephrosis is a special entity during a pregnancy. And when does it occur? It occurs mostly by the 7th week of the gestation in up to 90% of pregnant ladies, and may persist postpartum after delivery by 6 weeks. So في خلال أو بعد الأسبوع السابع بيبدأ physiological hydronephrosis، وهي ببساطة it's more to the right side by the way. And اللي هو dextroverted uterus غالبا بيعمل some sort of indentation or some pressure against the pelvic brim of the ureter, against the pelvic brim. ومن هنا بتجينا فكرة الفسيولوجيكال، لكن it could be pathological still. This physiological hydronephrosis is thought to result from hormonal two things. One hormonal and the other cause could be mechanical factor. Hormonal factor is leading to some sort of dilatation of the ureters. In addition to there is a relative obstruction to the ureter against the pelvic brim by the pregnant uterus is an additional factor to cause this hydronephrosis. يبقى two factors, one hormonal due to progesterone leading to some sort of dilatation of the ureter, and the other one is the mechanical, and it's more pronounced on the right side. How do we distinguish physiological hydronephrosis from intrinsic obstruction due to distal ureteral stone disease? Again, let us think in a good way. You know, just we have mentioned that the ureter could be relatively obstructed against the pelvic brim. So the part of the ureter just above the pelvic brim could be dilated, but lower down it couldn't be. And this sometimes could be detected by simple ultrasound for this patient. Let us see how we are discussing this. So physiological hydronephrosis typically more impressive on the right side and generally terminates at the pelvic brim. If it is going more and more, we are to think of something else. I mean, just going to the bladder. We are to think of ureteral obstruction, secondary to a stone or secondary to any other. You know, luminal structures could be obstructed, by the way, from something inside the ureter, or something in the ureter, or something in the wall of the ureter, as any luminal structure. So we have to think of those things very well. Imaging suggests, imaging by that we mean doing a simple ultrasound, a physiological hydronephrosis, and how, the next question, important point, how could we manage this pregnant lady? Occasionally, physiological hydronephrosis may be painful, requiring analgesics, so analgesia could be given and be relieved by positioning the patient on her left side if the pain is on the right side. Just positional. I mean, uh, household measures could be the patient to have a rest on the other side to rest, so to let the uterus go away from the ureter, and to have some analgesics. Occasionally, not very common really, we could need to do some sort of ureteral stent as if we are bypassing or put a stent, as we may have mentioned in our second lecture, that ureteral stent that it's in the bladder and the other end is the renal pelvis. It might lead the urine to go there without a proximal obstruction with hydronephrosis and back pressure to the kidney. Or simply a nephrostomy, but a nephrostomy is a troublesome thing, but sometimes we need to do that according to the feasibilities we are having in our facility. So putting a tube percutaneously at the region of the renal pelvis through the substance of the kidney, we call it nephrostomy. If we could do this if the symptoms persist and the patient had to be relieved. However, hydronephrosis in a normal physiological is a normal physiological finding during pregnancy, and if asymptomatic or only minimally symptomatic, intervention is not required, and we don't like it really. Among the investigations we could do for such a patient is to measure some of the blood tests to see the kidney functions. Say her creatinine was done for this patient, serum creatinine, and it was zero point 0.4 milligram per deciliter. But her baseline before pregnancy or at the earlier in the pregnancy, her baseline serum creatinine is zero point 0.8 milligram per deciliter. What does this mean? How could we explain? Is it pathological? Is it secondary to this obstruction? And what is its significance really, clinically? So this is simply during a pregnancy. Pregnancy by itself is associated with increased cardiac output and decreasing the systemic vascular resistance. So the cardiac output will be increased, blood volume will be increased. This will lead to concomitant increase in the renal plasma flow and enhance the glomerular filtration rate. Glomerular filtration rate, it has been shown, it has to increase about 40 to 65%, about half of the GFR will be increased in comparison with pregnancy values. This increase of GFR results in a decrease in all elements in the blood, by the way, not only the creatinine. It results in a decrease in the average serum creatinine level from zero point 0.8 to zero point 0.5 or zero point 0.4 during a pregnancy. And this is having a great implication clinically if the patient is to have any medications during a pregnancy, the bioavailability may be affected, and serum creatinine values that would otherwise be considered normal. So we are to consider the bioavailability or effect of this drug, which more or less has been diluted, let us say, in the blood circulation and in the bigger blood volume in, in this lady. And this is to be considered clinically. Let us have the other point. The flank pain resolves with conservative measures, that's to say, analgesia, positioning, and but she came to the clinic in 2 weeks later. Her urine analysis did show some bacteriuria, but she is asymptomatic. We call that asymptomatic bacteriuria. How shall we treat this? The idea behind this question, generally speaking, we did know that we are treating urinary tract infection when the number of colonies or organisms in a culture has been counted to be 10 to the power 5. That's to say 100,000 per cubic millimeter. But because of the risk of acute pyelonephritis in such pregnant ladies, current guidelines is recommending that pregnant women should be screened at 16 weeks to see if she is a liable candidate for pyelonephritis. It's a serious issue. Will put your patient in some sort of toxemia. And that's why we are considering the bacterial count of 10 to the power 2 colonies should be considered as significant in a pregnant ladies and supposed to be treated by this figure. Because asymptomatic bacteriuria could be progress to be could be worsened to symptomatic one, and the possibility of acute pyelonephritis will be increased up to 3, 4, 5 times even. Acute pyelonephritis occurs in about 1 to 4% of a pregnant woman, up to 20 to 40% of women with untreated asymptomatic bacteriuria. That's why we are by urine analysis and doing culture 10 to the power 2 is to be treated in pregnant ladies. What do you think is the proper antibiotics which could be safe when we are to think of the baby will be safe for the fetus and for the mother herself, and what are the antibiotics that are contraindicated? Let us start from this green one. Safe antibiotics are penicillins and cephalosporins. And please, whenever a pregnant lady, whatever her trimester, yes, first trimester is the most serious one, but give penicillins and cephalosporins all through. But contraindicated, fluoroquinolone, erythromycin, and the chloramphenicol with tetracycline. Of course, we know tetracycline, being precipitated in the bone and in the teeth, if there is anything, chloramphenicol, dry baby syndrome, all of those are contraindicated fairly. We are to use with cautiously. Those were nitrofurantoins, that urinary antiseptic. Risk of fetal anemia could be there in the third trimester in patients with glucose phosphate dehydrogenase deficiency mothers. So take care. You might not ask for that, but let us take care. Aminoglycosides like gentamicin, amikacin, those are known to cause ototoxicity and nephrotoxicity, so better not to give. Sulfonamides, there are risks in the neural tube defects related to the anti-folate metabolism in the first trimester. So please take care. Trimethoprim, like Septrin or Septal, we call it in this area, risk of neural tube defects related to the anti-folate metabolism in the first trimester. Still, this is very important antibiotic. So the safest one is penicillins and cephalosporin. What are the causes of pregnant lady might cause right-sided abdominal pain? This is a general question for us, and better always to think of everything together. Right-sided abdominal pain, upper or lower. Appendicitis is one of the common causes for that. Pelvic inflammatory disease, like in a differential diagnosis, even for the appendix. A cholecystitis, right-sided upper abdominal pain, pyelonephritis, perionephric abscess, lymph nodes, Crohn's disease, plenty of symptoms could cause, like any other patient. There are some causes related to the pregnancy itself, present, complicating the pregnancy, like an ovarian cyst or ectopic pregnancy. A lot of causes like any other lady she could have. In addition to the specific causes related to the pregnancy, like abortion, like whatever cause could be related. Are pregnant women at increased risk of stone formation? The pregnant lady is like any other creature. She is having no increased risk for stone formation, but definitely there is some sort of dilatation of the ureter. There is some sort of relative stage, so she could be a little bit more, but generally speaking, no increased risk. On the other hand, there is a hypercalciuria which could occur commonly in the pregnant ladies, primarily due to increased intestinal calcium absorption, and the patient is taking care of her, could be taking more milk, more vitamins, as well as increased calcium filtration. However, rates of stone formation remain unchanged in the pregnant ladies because the level of inhibitory factors for stony production, such as citrate, we know the higher the citrate, the less is the stone to be formed, and it is increasing in the pregnant ladies. Magnesium and the glycoproteins also being increased. If the ultrasound was not an adequate tool for diagnosis, cannot give a definite answer for a stone or to explain the hydronephrosis. How would you image this lady? Shall we request a plain X-ray? Shall we request a CT scan? Shall we do an IVP? Shall we do an MRI? A lot of the questions are coming in here. Really, uh, ultrasound is the safest, and X-ray is forbidden really in the first trimester of the patient because X-rays will affect the fetus, and in the fetus they're rapidly dividing cells, and organogenesis is being formed, and this definitely will be affected in the first trimester. However, intrauterine exposure during the second trimester may also produce some adverse effects. Still, we don't like it, but let us consider this in mind always. Generally, ultrasound is the safest, really. CT scan is generally avoided in pregnancy because still high radiation to the patient, but low dose or ultra low dose CT scan as for a stony protocol can be done. Recently has been advised, and some papers are written for that, with just a three or like a three-shot IVP, three shots only. So ultrasound imaging with a three-shot IVP by the way, magnetic resonance imaging is still safe in pregnancy and can be done. But a low dose CT scanning protocol can still be considered in selected cases. So generally speaking, for this patient, an ultrasound is the safest one. MRI, another safe one. Ultra short, ultra low dose CT scan could be done, and the three-shot IVD could be. This is in serial how to judge on things. If an obstructed stone was found, say an ultrasound that there is a stone in the distal or in 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 the course of the ureter, what treatment options are available? Shall we do lithotripsy? Shall we do surgery? What shall we do for this patient? He is complaining frequently. The safest for this patient is to do to do it endoscopically. Ultrasound lithotripsy is the best one, but sometimes we could relieve the obstruction, as we said earlier, by by a double J stent or percutaneous nephrostomy. But retrograde urethral stent from the urethra through urethrocystoscopy and pitting a ureteroscope, and through ureteroscope we could fragment, do lithotripsy for this stone while being in the ureter. This is another safe maneuver to do really in this patient. Sometimes ureteral stent could be irritating the lady, and it could be some sort of pain. So lithotripsy for the stone could be one of the choices to do. What definitive therapies are there for symptomatic stone during pregnancy? What shall we do? Symptomatic, there is a stone and the patient is really complaining. What definitive treat? Shall we do definitive therapy while she is pregnant or waiting till she can deliver? Yani by logic, I think we can wait till she is delivering. There is no absolute contraindication for surgery, for interventions during a pregnancy. But shockwave lithotripsy is definitely contraindicated. Percutaneous stone extraction is still not advised. However, ultra ureteroscope, as we mentioned earlier, have been shown to be safe and effective treatment for nephrolithiasis in all three trimesters of pregnancy. So ultrasound lithotripsy is one of the good thing, or ureteroscope with the Dormia basket, we could catch the stone and come with it out through the ureteroscopy, really. Physiological hydronephrosis facilitates by itself the passage of a stone if we are given the chance to wait and see. Facilitate the passage of the passage of ureteroscope with the ureter, and the lithotripsy can be performed as we mentioned. For this, this is another case of a 69-year-old patient. What is this, you think? This is a CT scan, isn't so? The right, this is the right, this is the right, this is the left. Better to know the CT scan, how to read it always. And this is the spine, this is anterior, this is the right, this is left. So this is a 69-year-old woman with a history of left renal stone, with left renal calculi, known with left renal history, with left renal calculi, who presented with recurrent left flank pain and a Proteus urinary tract infection. Proteus urinary tract infection. Here we are expecting the urine to be alkaline. So it's good to know that still and to keep it in mind. So here the history is telling us there is a left renal calculi who presented with recurrent left flank pain, recurrent, so long ago she is having this pain, and there is a Proteus. Whenever, by the way, there is a stone, there is a concomitant infection and vice versa. Think of it always. Look at it, and this is scan just to the left here. This is the region of this kidney. This is the left kidney, and this is the right kidney. Here is the spine. Here, as if the renal pelvis, but this renal pelvis is dilated, by the way. Here, there is a radio opaque shadow, like a stone in the substance of this kidney, as if she is going to pass this stone again, you know. Coming to the next CT scan film in this area, this is the kidney on the left side, and this is a huge dilatation of the renal pelvis, really huge dilatation of the renal pelvis. And there is a stone in here. But what is the cause of this recurrent colic and recurrent problem in this patient? Is it the stone in the substance of the kidney? Unlikely, of course. Either in the upper, I think it could be in the upper pole. Don't know exactly, but we shall take the CT scans and judge on the thing. It is not causing it is not causing pain, the stone in the substance of the kidney itself. But there must be another cause for this pelvis to be dilated just distal to the pelvis. It is it a pelvic junction stenosis and causing this? Yeah, the patient is elderly, by the way. PUJ, pelvic junction stenosis, could be could be present in an earlier stage. This is the way how to tackle, how to think of such a case. Let us see how we can approach this. There is no fixed answer to this question. We don't exactly know because exactly as we have been discussing together. However, the response should be similar to the following. The CT scan shows an 8 millimeter calculus, exactly what we have in the radio opaque one, in the lower pole, which is not causing symptoms, this one, but in addition, shows a dilated left renal pelvis. We have seen that with a normal ureter below. CT scan, other films did show that. Suggestive of PUJ then, yes. So there's pelvic junction obstruction, that's why the pelvis, the renal pelvis being dilated. The best means of confirming this obstruction could be a diuresis renogram like MAG3. A retrograde ureterogram can show that still, and would also ensure the ureter itself if it is normal. And what do you think could we how to manage this patient? Of course, the answer, we are to release the obstruction. This PUJ obstruction has to be treated. So the treatment had to be pyeloplasty, as if we are dilating the, the exit of the renal pelvis and its attachment to the ureter. So pyeloplasty, endopyeloplasty, retrograde or antegrade, or balloon dilatation of the ureter if the patient is not fit for that type. Balloon dilatation, this is something endoscopy could be done if our patient is not fit for very well for surgery. Of course, there is a Proteus infection. We have to give the proper antibiotic for that. The patient was referred for further shockwave lithotripsy, ESWL. As well, sometimes you are calling that for the stone if it is causing some any other. And this is a very interesting case. For this is a young man in his 40s and just presented with this picture of X-ray. What do you think is the abnormality in this X-ray before just coming and to jump and to say this is this or that? This is the spine, this is the pelvis, the bony pelvis, and this is the inlet of this pelvis. This is the ischial spine in here, and this is the sacrum, and this is number 5, 4, 3, 2, 1. Always we are counting the lumbar spines from below. 5, 5, 4, 3, 2, 1, and the D12 will be there. If we are to look for stones in this KOB, so we are to look at the tips of the transverse processes. Those are so we are to look at in here. Is there anything in here or in the renal shadow here? We cannot see anything. Let us go to the other side. This is the psoas shadow, by the way. This is the psoas shadow, we call it. This is psoas shadow. Very important to know psoas shadow. Coming to transverse processes. So there is something whitish here, this thing. There is an longitudinal stone, I think, radiopaque shadow, we can say. We cannot say a stone straightforward, but this is the site of the stone, whereas the ureter at the tips of the transverse processes between lumbar 4 and lumbar 5, nearly, approximately here. So this is a longitudinal structure, could be a radiopaque stone on the left ureter, mid-ureter mostly. We are talking about the ureter upper 1/3, middle 1/3, and lower 1/3. This is mostly the middle 1/3 of the ureter. So what does the X-ray? This is a KOB showing radiopaque stone between the transverse processes and near their tips between 4 and 5 coming. What other investigations you think could be done for this patient to make it clear? By the way, currently speaking, CT scan is one of the good ones, the good tool so as to diagnose. Then let us come to the treatment. Let us see. This CT scan, this is CT scan already requested in here, and it showed fairly stone, really. This CT scan of the same previous patient confirmed a large calculus in the mid part, middle 1/3 of the left ureter with marked dilatation of the ureter above it in some other films, we have seen. How to answer this question, how to treat it? Claim shows a large opacity 2 cm by 1 in the line of the left ureter, consistent with the large ureteric stone. CT scan is needed to confirm we did the CT scan and metabolic workup if the stone passes. I mean, if needs even to do the parathyroid hormones, we are to do that. No problem. Or to do what type of stone is this one? Is it ureteric? Is it an oxalate stone? Is it ureteric stone? Is it a uric acid stone? What sort of xanthine stone? It is a stone of this size is unlikely to pass a spoon. Sometimes the smallest stone below 5 mm in diameter it might pass spontaneously, but this is long one, 2 cm by 1 cm, that could be impacted, whereas there is dilatation of the left ureter as has been mentioned before, and requires surgical intervention. The preferred treatment modality for stone of this situation should be ureteroscopy, putting the scope in the ureter itself, and laser or ultrasound lithotripsy, just on the stone itself, ultrasound waves or laser will fragment this stone. Sometimes we might need to put a double J catheter during fragmentation or lithotripsy of this stone, so as no single piece will obstruct the ureter during the course. This is another case of a healthy 22-year-old man presents to the emergency department with moderate to severe pain in the left hemiscrotum. So this is a young man, active young man, 22-year-old, presents to the ED with a moderate to severe pain, whereas he came to the emergency room. So you consider it always significant complaint about this patient, and there is a pain in the left hemiscrotum. Once the patient came this way, you are to put some things in mind. What is in the left hemiscrotum? There is the testis is there, the epididymis is there. Is the patient having any trauma, let us see. He reported that the posterolateral aspect of the left testis is very tender. Posterolateral aspect, look at it. Posterolateral of the left testis is tender to palpation. He himself, the patient, and we are examining mostly, he will have this tenderness. Again, posterolateral aspect of the left hemiscrotum is tender to palpation. Onset was gradual over the past 3 to 4 days, and is coming to us 3 to 4 days after. Let us see how things will go. So, what is the provisional diagnosis in this patient, and what is the differential for that? A young man, just please, before shifting to the next slide, think of it. What could be? Is it epididymitis? Is it orchitis? Is it epididymoorchitis? Is it secondary to a trauma? Is it secondary to some sort of infection ascending to him through a UTI or through a certain contamination? What could be the cause for this? Is it a hernia obstructing in there? But he didn't mention a swelling in there himself, the patient. But he is having some pain in the area, but think still of everything. Let us come and see. So epididymoorchitis is one of the common things in this young man. The trauma can cause that. Torsion of the testis, if it is before it is not fixed well in there, unlikely, but it is, this young age, but slow onset might be testicular tumor, some infarction in the tumor, or sudden bleeding in a tumor. Unlikely because typically non-tender tumor. You know, what further would be helpful to reach the diagnosis for this patient? What shall we do? Shall we do urine analysis? Shall we do an ultrasound? Shall we do a CT scan? Shall we do a duplex imaging? Duplex for the blood supply. For the trauma, there is no history of the trauma, or it could be, we don't know. Let us see. So go back to the history of this patient. Take the patient as we have said how to approach. Take good history, examine your patient, then come request some investigation, then reach your diagnosis. So voiding history, how is the urine being void? How is the urinating? Particularly irritative symptoms, like strangury or dysuria or scalding pain or hematuria. Is there any odd sexual history in this patient? Not always we are having the patient being frank with this, but we consider. Is there any history with trauma? Take that history from this patient. Further history, again, you will ask for the trauma. There is no history of the trauma. The patient reports as moderate irritative voiding. He said, yes, there is a scalding pain, there is dysuria. He is sexually active, mentioning that. But by examination locally, by physical examination, they demonstrate swelling on the left epididymis with moderate tenderness. We are coming to the diagnosis now. The overlying skin of the scrotum is not erythematous and essentially normal. And this is the picture of epididymoorchitis, by the way. Skin is okay, but deep palpation of the epididymis or spermatic cord, let me say, will be tender in this patient. What do you think then is mostly the diagnosis in this patient? What further clinically based evaluation should be done? Think of it. So the diagnosis mostly will be epididymitis because the testis was not fairly tender, but only the epididymis. Why we are having this patient is a young man, sexually active, less than 35 years old. It is not a rule, of course. Any patient, any young man can do whatever. The most likely etiology is a sexually transmitted disease in this patient. The lack of scrotal skin changes make a scrotal abscess unlikely. There is no yet, but if neglected, it might be. Investigations, you have to do urine analysis with culture and sensitivity, urine test for gonorrhea and chlamydia. This is very important. Urethral swabs are no longer indicated like before. You are not doing this testing for gonorrhea. Is there a role for imaging of this patient? If so, what would be expect to find? What we are expecting to find? You know, imaging by an ultrasound, say, or imaging by a duplex. And duplex will be helpful during, say, if there is a blood supply jeopardy, like torsion. But a torsion, we have said, it is unlikely. A tumor is unlikely. To do a simple ultrasound. So let us see how things will go. The patient can be treated empirically or in your clinical examinations. You are confident with your examination, and imaging can be withheld later on if any complications come really. But we can treat this patient clinically. If imaging was to be done, ultrasound can help for that. This may demonstrate increased blood flow. In inflammatory processes, the blood will be more going to the organ, to the epididymis and testis on the left side, reflecting inflammatory process if an ultrasound or duplex is being done. How shall we treat this patient? Is suprafloxacillin, which is fairly common currently, the people know that. All your patients are aware of this. Standard recommendations for treatment of epididymolysis in young men less than 35 years old include the course of fluoroquinolone, such as ofloxacin, Levox, or something like levofloxacin. This antibiotic will cover both the chlamydia in addition to the other organisms. It's very good, really. Levofloxacin. Ciprofloxacin is not a good choice because it will not cover chlamydia. Chlamydia, as we know, it is between the viruses and bacteria, and there is something like rickettsial infection, but it is responsive to levofloxacin really, and and what is known as doxycycline. Both combinations can do good in this entity. Doxycycline at a dose of 100 milligrams twice a day. But here, very important always, we are stressing the point to treat the patients for weeks, not just to give a course of 5 days and that's all. No, give your patient 3, 4 weeks for a young man and to stop any other activities or sources of possible infections. Classically, a third generation cephalosporin can still do good, really, for this patient. Non-steroidal anti-inflammatory will help him, like cataflam, diclofenac, or whatever. What are the adverse sequelae that can observe in a patient such as this patient with epididymitis or uh, some other extension? Of course, the extension could be to the testis itself, or if it is progressing, it might be, what do you think? An abscess? It could be an abscess still, why not? Let us come. So abscess formation is there. Testicular infarction will be the possibility. Testicular atrophy secondary to this damage of the testicular tissues will be there. And secondary to that could be infertility, but foreign gangrene if the skin of this patient is being affected and immunocompromised patients if he is like that. So foreign gangrene is another possibility, which is serious issue. Further evaluations and counseling should be considered for this patient, like an advice, how to behave, how to advise, how to not to accept good cleaning and taking care of himself in coming years. In elderly patients with epididymolysis more than 35 years of age, the organism here is a little bit different from the younger age group. The typical pathogens, what are the pathogens in those patients in the elderly? Let us see what they could be. In the elderly, in the older patients, the typical UTI pathogens are observed and they can be treated with a fluoroquinolone or Bactrim with the adjustment based on the culture and sensitivity. Sometimes the infection will be gram-negative bacilli like E. coli, like Pseudomonas. So on the best is there to give the antibiotics according to culture and sensitivity. But always you are stressing the point the patient could be empirical treatment, assuming what organisms could be in the patient, give the empirical one, do cultural sensitivity, and in a view of the culture, you can continue. You cannot leave your patient 2, 3 days with continuous infection and not to treat. So if there is obstruction in this patient, like prostate, like urethral stricture, you are to treat the obstruction. You know, if there is a stone, you are to treat a stone. In younger and pre-pubertal boys with epididymorchitis, what abnormality can play an etiologic role? What we think? Is it a congenital anomalies? Is it infections? Is it and what sort of infections in the younger age group? We see in the elderly how process can go, but an ectopic ureter, congenital anomalies could be there. Ectopic ureter, the ureter is not in its normal location opening in the just in the angle of the trigone of the bladder, but it might open in posterior urethra. It might open here or there in the bladder. It might open in the, in the coitus. We know an ectopic ureter or from a duplicated system can drain into the vas itself, uh, in the vas or seminal vesicles, and predisposed to epididymoorchitis. And we are to think of this. If it is recurrent, you are to think of that because they're taking pre-implantation of the ureter. This is not a common presentation, but we had to know that. Viral origins for epididymitis can be there also. This is a very interesting case concerning the renal trauma. And renal trauma is a very important entity we had to know, by the way. The golden rule in renal trauma is conservative management. We are to conserve the renal tissues as much as possible, but not on the expense of the life of the patient. This is, of course, definitely had to be conserved, but conservative management is the rule. Why the kidney being retroperitoneal extraction and being tamponaded by the posterior peritoneum and the abdomen and the back, the strong muscles on the back. So it could be tamponaded if any hematoma or any collection, and if the patient is stable, we can just observe. This is the general dictum regarding the renal trauma. This is a 14-year-old female patient presented to the emergency department with a right loin pain, where the kidney is, and gross hematuria. There is blood in gross hematuria, blood all through, on a fall down on a bench in her classroom over her right flank. وقعت المريضة هذه على جنبها من الناحية اليمين وإجت برايت flank pain وجروس هيماتوريا. The type of the trauma, what is the type of the trauma? Is it a deceleration injury? It is not, because a deceleration injury, the patient will be running or in a car running, then stopped suddenly, and on that basis, the kidney could be avulsed from its pedicles, the vessels, or whatever being fixed in there. But here, just she received a blunt trauma on her left flank, direct trauma to the kidney. While I am reading, of course, I am interpreting the mechanism of the trauma or kinematics of this trauma is very important. How did the trauma happen? Because it might illustrate for me the type of injury I could have in this patient. So it's a blunt trauma to the right flank, a gross hematuria and pain. And her age is 14 years old and she is female. She is stable. Her blood pressure is 130 over 85, and her heart rate is 67 per minute. You know, blood pressure is normal, more or less. Her heart rate, 67 per minute, is not even in tachycardia, and her blood pressure is normal. Isn't so? She has no flank ecchymosis. There is no big trauma, big, say, laceration or ecchymosis to the flank, but has a small, tender, palpable mass in the right upper abdomen. There is a mass in the upper right abdomen, but hemodynamically stable, the patient. Her hemoglobin is at 12.5. Wow, her hemoglobin is more or less normal. But always consider that the hemoglobin, the first reading of the hemoglobin, we are to consider it is not reflecting the normal status of the patient. So just keep it in mind. Her creatinine is zero point 0.8, normal again. Her urine analysis reveals innumerable red blood cells plus one protein. Her CT scan report reveals a severe laceration of the right kidney with a large surrounding hematoma, with which affects the kidney anteriorly and laterally. The main renal artery and vein appear intact. Ah, good. So far, so far. No contrast is seen in the right ureter, but there is also no definitive evidence of contrast extravasation from the right collecting system. Yeah, to start with, not very, very bad news concerning the parenchyma of this kidney, but let us see and observe. What do you think before shifting to the next slide? Uh, the management to start with, or what to do? CT scan is done, hemoglobin done, you know, this is a patient more or less stable and her blood pressure okay, pulse rate is okay, hemoglobin okay, there is no extravasation, and the patient must be talking and communicating well. Mostly, I think that the management will be like this. Let us have the first question. What are the important points need to be able to inquire about in a case like this of renal trauma? What to discuss, what to put in mind. It's very important, really. Look at the mechanism of the trauma. As we have mentioned, it is not a deceleration, as we have mentioned, just a direct trauma to the line. Rapid deceleration injuries, the explanation for what happened here. Rapid deceleration injuries are associated with vascular pedicle disruption. Deceleration, as I said, while the patient is going in fast, stopped suddenly, this is a deceleration. It is not deceleration, this one. So rapid deceleration are associated with avulsion, and that deceleration causes avulsion of the pedicle disruption or thrombosis, as well as PUJ disruption. And this patient didn't like this. Vessels are that have been delineated, both of which are unlikely in this patient given the mechanism of the injury. The age of this patient, concerning to consider also a matter of discussion, as we have mentioned in the previous slide. Age of the patient, the kidneys are less protected. Her gyrota fascia, her surrounds are not yet protected very well, like in the adults. The kidneys are less protected by surrounding gyrota fascia or fat, and the rib cage in the children. Renal vessels and ureteral avulsions injuries are more common in this subgroup of age. Yes, good to consider that. Good to know this. A history of renal ectopia or anomaly, we are to think of it still. These kidneys are more prone to injury if it is ectopic and may have anastomosis vasculature. A gross or microscopic hematuria while a stable patient, like in this patient with microscopic hematuria, do not require as aggressive evaluation. It should be noted that the degree of hematuria doesn't always correlate the hematuria, the degree of the injury even, with the severity of the injury. Not always the prophysio means severe injury, not always, but this is just to keep it in mind. Up to 36% of renovascular blunt trauma are not associated with hematuria. This is very important. The patient could have very bad injury in the kidney, and still the patient might not have hematuria. This is very important. Was it the preferred imaging method for stable patients with suspected renal injury? What do you think? An ultrasound, a CT scan, MRI? We have done the CT scan urogram, specifically for the kidneys, with a 10 minutes delay. Take them, give the dye, then after 10 minutes, do the CT scan. So as to delineate in a very, very good way. Who should be imaged in renal trauma? In renal trauma, who we should لمين نعمل CT scan. CT scan mostly is the rule for it. This is more objective. So CT scan or imaging for the renovascular tumors, it had to be done for only blunt trauma patients with a gross hematuria. Gross hematuria, CT scan must be done. Patients with microscopic hematuria and shock. As we mentioned, absence of hematuria even doesn't mean there is no bad injury. Patients without either of the above one and two, but with a high risk mechanism of injury, that's to say rapid deceleration, to see any other associated injury. Patients with penetrating trauma had to be explored, scanned, imaged, and degree of gross hematuria. In children specifically, it's controversial because exposure by a CT scan sometimes will cause some sort of carcinogen, big amount of radiation will be exposed, but the other idea is to manage the children like the adults, only with the precaution of possibility of oncogenesis there or radiation exposure trauma. Uh, when to think that a patient with renal injury is having a major injury, major, yeah, that's to say, renal artery, renal vein, or avulsion of the renal pelvis. Number one, the possibilities are a medial hematoma being accumulating after injury, suggesting a vascular injury medially to the medial border of the near the hilus, the hilum of the kidney. Medial hematoma in there. Medial urinary extravasation suggests possibility of renal pelvis or urethral lacerations or lack of the contrast enhancement of the entire renal parenchyma. There is no contrast, no uptake of the renal tissue. So those are the three entities which indicate there is a major injury in this patient and might need some sort of exploration. Really. What is the recommendation for this patient? Number one, the patient should be admitted to the hospital. Say conservative management, serial vital sign monitoring in the ICU for 24 hours or more, observation on the regular nursing floor in the ward later on. She should be kept on complete bed rest with narcotics, completely relaxed and pain free is to be kept. Observation, conservative management for that. What are the indications for surgical intervention in such a case? Whereas she is stable, will be no problem. Yeah, let us see. Patients who remain unstable لو ضلتها مش stable المريضة, this is the one to be managed surgically. If resuscitation is going on, she is responding for that, because mostly by such a trauma the patient might need a nephrectomy or could need renal repair to the tissues of the kidney. The vessels are okay that have been shown by the CT scan. However, the vast majority of patients, even with high-grade laceration, respond to resuscitation, and this is the rule in the renal injuries, and are stable. These patients can be managed with bed rest and observation. Other than hemodynamic instability, indications for immediate interventions, that's to say surgical, is a major vascular injury which is not apparent or disruption of the PUJ junction. But while under observation, delayed interventions may be required later on, after delayed interventions may be required for persistent hydronephrosis, in spite of being stable, but persistent hydronephrosis, something obstructing, something is stenosing, usually managed with ureteric stent or an infected urinoma, infection with vasculation, and it had to be drained, had to be interfered with the hematoma. And this could be drained percutaneously. This patient did well without intervention and was discharged home. 2 weeks. 2 weeks later, after injury after the injury, the patient who is 14 years old, she returns to the emergency department with the complaint of increasing abdominal pain and an enlarging abdominal mass. CT scan did reveal the following. Number one, a large perinephric collection measuring 13.4 by 4.9 by 10 centimeters. A big collection, really, adjacent and posterior to the right kidney. There are symmetric nephrograms. The kidney is taking the dive, functioning. A parenchymal defect is seen in the mid and lower pole of the right kidney. No urine leak is seen. Her hemoglobin was 7.5, low, dropped. It was 12 something. She remains stable but requires periodic transfusions. What is the recommendation now? Let us see. The patient should undergo angiography to see the vessels, how is it looking like. Delayed bleeding after renal trauma can be a sign of arteriovenous malformation. Wow, this is very important point, and we are to think of it. Is this patient having an arteriovenous malformation, which can be managed by embolization even? Look, this is a very intelligent idea. In the interventional radiology suite, the patient, yes, the patient is indeed found to have AV malformation. Unlucky patient, what shall we do? But it's good to discover it, to have an AV malformation which is successfully embolized. Great. She remains stable and ultimately discharged from the hospital. What shall we tell the parents about the need for follow-up and future risks for this little girl? There is a risk of another rebleed, though this is the greatest within the first 21 days of the injury. She has a lifelong risk of hypertension and should have an annual blood pressure check. A very nice case, really. This is strong. We are having still two cases, really, or three, I think, 8 cases we have. A 37-year-old woman has hypertension for 15 years. Young lady, 37, has hypertension for 15 years. Wow. 15 years, it means that while she was 22 years old, she recently had headache associated with high blood pressure, 180 over 105. Now she is on 4 antihypertensive and still uncontrolled well. So what shall we think of? In a patient like this, a young lady, there is something called, as we mentioned in our lecture, renovascular hypertension or some suprarenal pathology. Those are the two main big entities we are to think of, really, in such a patient. Not responding to 4 antihypertensive, still blood pressure 180 over 105. And it's a very significant presentation. What is the provisional diagnosis and what is the differential? Considering the early age onset and difficulties with control of this patient, this patient is likely to have secondary hypertension rather than essentially hypertension. And we are calling this type of hypertension, by the way, surgically treated hypertension, as we have mentioned before. If she is having a renal artery problem, it will have to be managed. Angioplasty. If it's suprarenal tumor, we shall remove. So surgery is there. I mean, intervention, I mean. The possibilities have here include renal artery or adrenal disease. The most common form of renal artery disease in a woman ages 20 to 50, like our patient here, is fibromuscular dysplasia, FMD. Very important to know this, by the way. Please keep this in mind. Or intimal hyperplasia or an aneurysm. Keep those three in mind. Fibromuscular dysplasia, FMD, or intimal hyperplasia or aneurysm. Or the other type is atherosclerosis, but unlikely in this patient because atherosclerosis in the elderly age group, the older ones. Adrenal pathology could include pheochromocytoma, hyperaldosteronism, primary Crohn's disease, or secondary, or Cushing's disease, hypercorticism. What are the clinical clues for renal artery disease resulting in hypertension in general? What are the in a characteristic renovascular etiology, onset is in an earlier stage, less than 30 years FMD, more than 55 years atherosclerosis, arterial ASO, atherosclerosis. So in the younger age group, think of FMD. But in the older ones, think of atherosclerosis. Accelerated or malignant hypertension or hypertensive crisis, hypertension associated with pulmonary edema, some sort of left-sided cardiac insult, sudden onset and short duration of hypertension. Smoking is a risk for smoking is very bad. How can we potentially differentiate between adrenal pathology and renal artery stenosis based on the history and examination? Just on the history and examination. It's a simple thing, by the way. More detailed history is to have more from this patient and examination to assess weight gain, palpitation, Cushingoid face, thin skin, easy bruising, abdominal striae, that might suggest Cushing's disease. So this is excluded, saying at least in our patient. The presence of bruit suggests renal arteries. Go to the loin and put your stethoscope in the loin. You might hear a bruit. Okay, this is a clinical. A low potassium, just the low potassium would suggest a hyperaldosteronism, aldosteronoma, high sodium and low potassium. Although there may be also secondary aldosteronism related to the renal artery stenosis. It's better to keep, have those in mind. What diagnostics tests should be done for this patient to rule out the other causes apart from renal artery disease? Basic lab investigations like the renal functions, potassium, plasma, metanephrines, a renal artery duplex will show the caliber of the disease and the flow of the blood through the renal artery is a good screening, at least a screening test. Duplex, yeah, it's a very good one. At least a screening test. This examination, it's very informative, by the way, with all the details mentioned in here. Just have a look at it. A basic principle is that stenosis associated with increased velocity through and after this type of in the stenotic area. Another test that should be considered is the angiotensin converting enzyme inhibitor renography. And the last one is the nuclear scintigraphy. Just have a look and read it in a nice way. What is the role for angiography? Shall we do an angiography? DSA or the gold standard selective angiography? Is it important? Yes, it is important. Why not? In patients with a compelling history, either an abdominal duplex or functional study, such as angiotensin uh, C angiotensin inhibitor, renal scan, or angiography should be done. Conventional angiography should be done for diagnosis, but has largely been replaced by CT scan angiography itself, as we have seen the nice pictures in our second presentation, but it is non-invasive and offers sufficient resolution to direct further therapy. The main reason to do catheter-based angiography, the, the interventional catheter-based angiography is that if you could find a stenotic renal artery, you could do some sort of angioplasty, that's to say balloon dilatation or inserting a stent. Some experts have recently advocated the use of intravascular, this is very recent by the way, intravascular ultrasound to clarify the diagnosis and put a stent or to do the angioplasty. Intravascular ultrasound is more sensitive than angiography for determining the extent of the disease. The management options and what are the limitations of each? What is your final recommendations for this? Management options are simple ones, but very gross, really. Medical management, she is now on 4 medications, the patient, with poor control, so she is no longer effective and long-standing hypertension. She might have another insult like CVA, like whatever, so she must be treated. Endovascular management for disease restrictive to the to number one, main renal artery angioplasty is the preferred treatment. So main renal artery angioplasty, stenotic, fibromuscular dysplasia, because it provides effective and double resolution of hypertension. So it's very nice. Surgical intervention, simple main renal artery renal revascularization offers no advantage over endovascular management. So endovascular management is fairly preferable, or do some sort of auto transplant to take the left kidney or the right kidney to put it in the right or left iliac fossa, vice versa, really. So as auto transplant to take the kidney from one side, from the loin, and to put it in the left or the other right or left iliac fossa. In this case, renal auto transplantation with vascular reconstruction is required. Or instead of having this longish suffer, a nephrectomy could be another option, but it might lead to kidney insufficiency. This patient, by the way, had renal reconstruction and auto transplantation. Thank you very much. Those are a number of clinical cases just to study to widen our knowledge and experience, how to tackle, how to diagnose, how to treat, how to think of approaching our patients. Thanks a lot for listening. I know it's a long lecture, but very important one. Just keep it in mind. Ask me whatever you like to ask and anytime. Thank you.